Bismillahirrahmanirrahim. Assalamu alaikum. Thank you for joining this session on management of dyspepsia. Dyspepsia is one of the most frequent clinical complaints in our clinics. It affects quality of life, creates anxiety, and results in repeated visits and investigations. Yet, in most cases, the underlying disease is not serious, and our main challenge is identifying the few cases that do need urgent attention while managing the rest effectively and cost efficiently. Over the years, the management of dyspepsia has evolved from vague symptomatic treatment to acid suppression to the era of H.pylori and now towards a structured algorithm-based approach that emphasizes identification of alarm features, wise use of endoscopy, test and treat strategies, functional dyspepsia management, and patient education and reassurance. In today's lecture, I will focus on clinical scenarios because dyspepsia is a highly patient-specific condition. You will see how small differences in age, symptoms, or risk factors can change the management plan completely. We will discuss what dyspepsia is, how to stratify patients, when to investigate and when not, when to test for H. pylori, practical treatment and follow-up strategies, and how to apply these decisions confidently in daily OPD. My goal is that you leave this session with clear algorithms that simplify your practice, save time and cost, and improve patient outcomes. So let's begin. Bismillahirrahmanirrahim. Management of dyspepsia. The learning objectives of today's lectures are to understand definition and classification of dyspepsia, to recognize alarm features and red flags, to apply evidence-based diagnostic strategy, to manage functional versus organic dyspepsia, and to use practical algorithms for daily practice. Before we start our lecture, let's have a pre-test. My request to you to please take the paper and write out the questions, answers which you consider are correct. The first pre-test MCQ is, the most common cause of dyspepsia in clinical practice is A. Peptic ulcer disease, option B. Gastric cancer, option C. Functional dyspepsia, option D. GERD, and option E. Gastroparesis. So on the paper, you write down the question number 1, and whichever answer you feel is correct, please write down. If somebody thinks it's peptic ulcer disease, Against the question number 1, write the answer A. If somebody considers it's B, gastric cancer is the most common cause of dyspepsia, write down B. If someone considers it's functional dyspepsia, you write down C, and similarly D or E. When we finish these questions, I'll share with you the answers, the correct answers. So, question number 1, whichever answer you feel is correct, please write out that option. Now the question number 2. A 55-year-old male presents with recent onset dyspepsia and weight loss. The most appropriate next step is A. Empiric PPI trial, B. Test and treat H. pylori, C. Dietary advice only, D. Upper GI endoscopy, and E. Abdominal ultrasound. So whichever answer you think is correct, please against the question number 2, write down that answer. Now question number 3. Which of the following is not an alarm feature? Which of the following is not an alarm feature? A. Dysphagia. Option B. Vomiting. Option C. Early satiety. Option D. Iron deficiency anemia. And option E. GI bleeding. So please pick one which you think is not an alarm feature. And against the question number 3, write down that answer, that option, whichever you think is correct. A, B, C, D, or E. Let's go to question number 4. In a 35-year-old male with dyspepsia and no alarm features, the preferred initial strategy is upper GI endoscopy, option A. Option B, test and treat H. pylori. Option C, CT abdomen. Option D, colonoscopy. And option E, barium meal study. So you write down the option which you think is correct. Question number 5. Which test has the highest accuracy for diagnosing active H. pylori infection? Option A, urea breath test. Option B, IgG serology. Option C, rapid urease test. Option D, stool for antigen. And option E, histology. Whichever option you think is correct, please write down that against question number 5. Now question number 6. PPI should ideally be stopped before H. pylori testing for option A, 24 hours, option B, 48 hours before H. pylori testing, option C, 1 week before H. pylori testing, option D, 2 weeks before H. pylori testing, and E, 4 weeks before H. pylori testing. So whichever answer you think is correct, please write down that option against question number 6. Now the question number 7. Functional dyspepsia is diagnosed when option A, symptoms persist for more than 1 month. B, no structural disease on investigations. Option C, malignancy has been excluded. Option D, symptoms improve with PPIs. And option E, psychological factors are identified. So whichever option you think is correct, please write down against question number 7. Now question number 8. Which drug is most helpful in postprandial distress syndrome? Option A, PPIs. Option B, antacids. Option C, prokinetics. Option D, H2 blockers. And option E, NSAIDs. So please note down the correct option in your thinking, whichever you think, against question 8. Now, question number 9. Which of the following increases suspicion for gastric cancer? A. High fat meals. B. Family history of gastric cancer. C. Smoking. D. NSAIDs use. And E. Bloating. What do you think? Which of the one of these statements increases suspicion for gastric cancer in patient with dyspepsia? Whichever you think is right, please note down against question number 9. Now the question number 10, the last question. Step-up approach in dyspepsia means option A, start with invasive investigations. Statement B, start with low intensity therapy and increase as needed. Option C, start with antibiotics for H.pylori. Option D, start with maximum dose PPIs. And option E, start with antidepressants. So whichever you think is the correct answer, please note down that against the question 10. And now I'll share with you the correct answers, and you give marks to yourselves that how many statements of yours are correct. This is the answer for MCQ 1, correct option C. For MCQ 2, correct answer was option D. For question MCQ 3, correct answer was option C. For MCQ 4, correct answer was option B. For MCQ 5, correct option was answer A. For MCQ 6, correct answer D. For MCQ 7, correct answer B. For MCQ 8, correct answer C. For MCQ 9, correct option B. And for MCQ 10, correct option was B. Now, so please give marks to yourselves. And after the lecture, we will have post-test MCQs and let's see how much improvement have you made. So what is dyspepsia? Let's start from the basic question. Upper GI symptoms lasting for more than 4 weeks means dyspepsia, and these include epigastric pain or burning, postprandial fullness, early satiety, bloating, belching, nausea sometimes. So any one or more than one of these symptoms, it compromises or it makes a definition of dyspepsia. So if anyone is having epigastric pain or burning, or postprandial fullness, or early satiety, or bloating, belching, or nausea at times, it may be one symptom or more than one symptoms, and these last for more than 4 weeks. We say this is a patient with dyspepsia. So some historical evolution. In 1970s, it was considered, dyspepsia was considered as a psychogenic stomach. That people who are at stress, who are anxious, they who got this dyspepsia symptom. Then in 1980, it was an acid suppression era. different sorts of acid suppressants. They were marketed and it was giving relief to patients with dyspepsia. Then in 1990, the H. pylori revolution came and everybody with dyspepsia was treated for H. pylori. Then in 2000s, the functional dyspepsia was recognized as a cause of dyspepsia. And today, we see the stratified therapy plus alarm features plus cost-effective testing. And this is the approach for dyspepsia nowadays. So the burden of disease. What is the burden of disease? Why we should be talking about the dyspepsia? 20 to 30% adults, they experience dyspepsia at some times of their life. And it's a globally, everywhere, every age, any gender. The GP and OPD visits, the patients with dyspepsia, they are in very high number, and we know that. Only 5 to 15% of dyspepsia have underlying serious disease. So this is another very important data, and we should keep this in our mind when we come across a patients with dyspepsia, that only 5 to 15% of those patients, they will be having underlying serious disease. Main GP challenge is who needs endoscopy. This is the main challenge. Should every patient be undergoing endoscopy? Yes or not? If not, then who are the patients who needs endoscopy? So I'll start with clinical scenario number 1. 45 years old male with burning epigastric pain, which becomes worse with food, and there is no history of weight loss or vomiting. No vomiting, no weight loss. He is using NSAIDs occasionally for his aches and pains. And there are no alarm features. What to do? So what is the next step to do in these patients? In this patient, 45 years old male, burning epigastric pain, which becomes worse with food, no weight loss, no vomiting, occasional NSAIDs. So it's a common case, we know that. And think approach is, of course, the age cutoff, risk factors, and alarm features. So the approach to this patient should be, as age is less than 50 years, he's 45 years, with no alarm features, so no immediate endoscopy is required in this patient. The options which we should consider are stops NSAIDs because he's using NSAIDs off and on, and give empiric PPI for 4 to 8 weeks. And the third option is test and treat H. pylori. So you can stop NSAIDs and see if this improves, or give empiric PPI for 4 to 8 weeks and see, or test and treat H. pylori and proceed accordingly. In most guidelines, test and treat for H. pylori or empiric PPI is acceptable. NSAIDs is clear contributing factor here, and that needs to be stopped. So, few words about the test and treat strategy. The preferred non-invasive tests for H. pylori are urea breath tests, stool antigen, which is good reliability, and avoid testing if patient is on PPI, because we need to stop PPIs 2 weeks before testing for H. pylori. And if the patient is on antibiotics and bismuth, stop 4 weeks before testing for H. pylori. What about red flags? What are these? If these are present in any patient, that patient needs immediate endoscopy and no empirical trial. So what are these red flags? Are alarm symptoms? These are if a patient presents with weight loss, persistent vomiting, dysphagia or odynophagia, GI bleeding or anemia, or if the patient age is more than 50 years with new symptoms of dyspepsia, or there is family history of gastric cancer, or their palpable mass or lymphadenopathy. So if any one of these is present, these are the alarm features and that patient needs immediate endoscopy. So the algorithm, if we, from this first scenario is, if age is less than 50 years and no alarms features are present, empiric therapy should be tried. But if age is more than 50 years or there are any alarm features which I discussed with you, then endoscopy should be done immediately before starting the patient on treatment. So a clinical scenario number 2, 58 years old male woman, coming with epigastric pain and weight loss. The HB is 9 gram per deciliter, and the patient presents with early satiety. So the immediate plan for this patient who presents to us with a 58 years old lady with epigastric pain, weight loss, HB 9 gram per deciliter, and with early satiety. Classic alarm features are there, the early satiety, weight loss, and low HB. So the immediate plan in this patient will be, of course, upper GI endoscopy, testing like complete blood count and liver function tests, and ultrasound abdomen. Because in this case, we need to rule out malignancy, peptic ulcer, and gastric outlet obstruction. So do not start PPI before endoscopy if possible. So let's classify dyspepsia. There's two types of dyspepsia, organic dyspepsia and functional dyspepsia. The organic dyspepsia causes for organic dyspepsia are ulcer or erosions, malignancy, upper GI malignancy, gastroesophageal reflux disease, and gastroparesis. The functional dyspepsia, when the patient has got normal endoscopy and no structural disease, and it fulfills room 4 criteria. In majority cases of dyspepsia, almost 75 to 80% or 80 to 85% rather, endoscopy is normal. The functional dyspepsia is the condition in majority of the patients who present with dyspepsia, and we need to understand its physiology and the brain-gut axis. So the few words about the functional dyspepsia, according to the room 4 criteria, what is that? If the patient has got symptoms for more than 1 month, and these are, there's epigastric pain or burning, if there's early satiety and postprandial fullness, and there is no structural disease, then this fulfills the criteria, room 4 criteria for functional dyspepsia. And we know there are two types of functional dyspepsia. One is postprandial distress syndrome or PDS, and the second is epigastric pain syndrome. The distinction between these two types of functional dyspepsia, whether it is postprandial distress syndrome or epigastric pain syndrome, is important, which helps you the therapy. For postprandial distress syndrome, you need prokinetics, and for epigastric pain syndrome, you need PPIs. Now the scenario number 3, 35-year-old female in which endoscopy is normal. She has stress at work, there's early satiety, bloating, and symptoms are there for more than 3 months. So in these patients of dyspepsia, the functional dyspepsia is the most likely diagnosis because endoscopy is normal, there is stress, and the symptoms are there for more than 3 months. So the management plan in this patient will be explain the diagnosis that this is a functional dyspepsia, it's not going to danger the life. Then lifestyle and diet is very important. She should avoid high fat meals and she should be using frequent small meals. PPI trial for 4 to 8 weeks may help, and the prokinetics may be tried, the domperidone, mosapride, or etopride. Education is critical in such cases, and combined approach works better. What are the psychological cofactors which are important, especially when you are dealing with the functional dyspepsia patients? These include sleep, stress, and anxiety. Poor sleep, stress, and anxiety, these are the contributors towards uh, causing and worsening the functional dyspepsia. So the use relaxation techniques and cognitive behavioral therapy if needed, these are very, very important. Low dose antidepressants may help, and in this we have the amitriptyline and mirtazapine. They can help in such cases. What is the role of H. pylori in dyspepsia? We know the H. pylori has got a strong link with ulcers and cancers. There's a modest link with functional dyspepsia. So the test and treat strategy improves symptoms. So always consider uh, the prevalence, and we know that in our setup in Pakistan, in Afghanistan, the H. pylori prevalence is very, very high. So whom to test? This is important. If a patient has got age less than 50 years and the patient is dyspeptic symptoms, that may be tested for H. pylori. If there's unexplained iron deficiency anemia, if the patient is on long-term NSAIDs, or if the first degree family history of gastric cancer is there, then better you test for H. pylori. What about the eradication regime if the patient is found to be H. pylori? The first line eradication regime is triple or quadruple therapy based on the resistance, and the treatment should be given for 14 days, and the test of cure should be done 4 to 8 weeks after the stopping of the therapy. We will be having a separate lecture on H. pylori infection, inshallah, in the days to come. So we will discuss all these in detail when in that lecture. So when to investigate, this is very, very important. When to investigate a patient with dyspepsia and what investigations should be. The routine investigations labs are complete blood count, liver function test, urea creatinine, stool for alkali blood. Imaging needs ultrasound upper abdomen and endoscopy if the patient is of more than 50 years of age, or if there are any alarm symptoms or the treatment failure is there, then we need to investigate this patient of dyspepsia. Please do not over-investigate mild dyspeptic patients. Coming to clinical scenario number 4, it's a 42 years old male, non-smoker, presenting with heartburn and epigastric pain, which becomes worse at night, and partial relief he get with 4 weeks PPI. What do you think what he's suffering from? Probably gastroesophageal reflux disease. So the plan for this patient will be, of course, increase PPI dose. Lifestyle modifications are very, very important. Avoid late meals. The head of the bed should be elevated. And if it's refractory, then we need to do endoscopy and pH monitoring. So many dyspeptic patients actually have reflux, and we should not forget this association. Few practical tips in such patients. Diet and lifestyle. The patient should avoid fat, spices, coffee, and chocolate. If smoking, should stop smoking. If overweight, weight loss is mandatory. The patient should have regular meals and avoiding lying down for 2 to 3 hours after the meals. So consult each and every patient if the patient has got symptoms of GERD, and lifestyle is underrated, but it's a powerful way, and we should discuss this with the patient. What about the follow-up strategies in such case? The long-term management is response to PPIs and prokinetics. Step-down therapy may be tried in this patient then, and risk of medication if the symptoms are recurring. So not all need lifelong therapy. Reassurance is the key, and the patient may be made out of that. When I refer a patient of dyspepsia to the higher tertiary care centers, when the symptoms become refractory, when there is weight loss, when the patient presents with dysphagia, or if there is suspected malignancy, or there are complex comorbidities, all patients falling in this category should be referred to the GI specialist referral. So, algorithm for a management of undiagnosed dyspepsia, and this is from the recent guidelines on dyspepsia in the American College of Gastroenterology guidelines. And what they say that adult dyspepsia patient, if age is more than 60 years, you can, in your setup, we can take this as a 50 years. Endoscopy should be done. If organic pathology is found, manage according to relevant guidelines. If endoscopy in this patient is normal, then manage according to figure 4 or table 4, which we'll discuss later on. But if the age is less than 60 years, in our setup it will be 50 years. Age more than 50 years, do the endoscopy and proceed accordingly. If age is less than 50 years, H.pylori testing should be done. If it is positive, H.pylori eradication therapy should be given. If response is there, it's a success. If there is no response, give the treatment of PPIs, and if H. pylori test is negative to start with, then again it's the PPI treatment. If the patient responds, it's a success. If the patient does not respond, then tricyclic antagonist or prokinetic should be tried. If the patient gives response, it's a success. If no response, then consider psychotherapy. So this is the algorithm which has been suggested by the American College of Gastroenterology, and the another algorithm where we come across the functional dyspepsia patient. So if the patient is H. pylori positive, give the H. pylori eradication response, it's a success. No response, give PPI. But if to start with the H. pylori test is negative, give the PPI. PPI response, you declare success. If the patient does not respond, tricyclic antidepressants. Response, it's a success. No response, prokinetics. Response, it's a success. No response, then consider psychotherapy. So this is the sequence how we proceed in these patients. So if I summarize all these algorithms, first step is assess symptom for red flags. If red flags are present in a patient with dyspepsia, do the endoscopy. If there are no red flags, go to the next step. And the next step is age. If age is 50 years or above, yes, do endoscopy. If it's not above 50 years, less than 50 years, then go to the next step. And next step is test and treat H. pylori or empiric PPIs and reassess in 4 to 8 weeks. And then the step number 4, if persistent, despite these, patient was not requiring endoscopy to start with because of the absence of the red flags or age less than 50. But if the patient is not responding, then do the endoscopy. If normal functional dyspepsia, management should be given to these patients. So the key takeaways from today's discussion is dyspepsia is common, but serious disease is rare. Age plus alarm features drive decisions. A test and treat H. pylori is practical, and PPIs and prokinetics are main therapies. Educate, reassure, and lifestyle modifications are very, very important. And functional dyspepsia requires holistic approach. And this is very, very important and basic requirement in these patients. So, before saying goodbye, let's have a post-test as we had a pre-test. Here again, I'll share with you the questions and you write down the answers of those questions, and at the end, I'll show you the key. So the first post-test MCQ is age threshold for direct endoscopy in new onset dyspepsia is generally age more than 35 years, more than 40 years, more than 45 years, more than 50 years, or more than 60 years. Whichever you think is correct, please write down that. Then question number 2. A 60 years old male with epigastric pain and melena should have A. Empiric PPI, B. Urea breath test, C. Immediate endoscopy, D. Dietary therapy, and E. CT abdomen. Whichever answer you think is correct, please write down that. Question number 3. A 35-year-old woman with dyspepsia, no alarm features, negative H. pylori, best next step is continue PPI for 4 to 8 weeks, option A. Option B, do endoscopy. Option C, do pH monitoring. Option D, antidepressants, give that patient antidepressant. And option E, colonoscopy. Whichever you think is correct, please write down that. Now the question number 4. Which is true about functional dyspepsia? Statement A, most patients have abnormal endoscopy. Option B, treatment response is poor. Option C, psychological stress can play a role. Option D, surgery gives best outcome. And option E, dietary changes have no benefit. Whichever you think is correct, please note down that. Question number 4. Question number 5. The preferred H. pylori eradication duration in most guideline is 7 days. Option B, 10 days. Option C, 14 days. Option D, 21 days. And option E, 28 days. Whichever option you think is correct, please note down that against question number 5. Now the question number 6. A patient on PPI requires stool antigen testing for H. pylori. PPI should be stopped for 24 hours before the testing, 3 days before the testing, 1 week before the testing, 2 weeks before the testing, or 4 weeks before the testing. Whichever you think is correct, please note down that. Question number 7. In functional dyspepsia, the most effective drug in epigastric pain syndrome is option A, prokinetics, option B, NSAIDs, option C, PPIs, option D, antibiotics, and option E, statins. Whichever you think is correct, please note down that. Okay. Question 8. The first step after detecting alarm symptoms in dyspepsia is empiric therapy, B, dietary modification, C, test for H. pylori, D, endoscopy, E, start antidepressants. Whichever answer you think is correct, please note down that A, B, C, D, E. Question number 9. A 48 years old man on NSAIDs develops dyspepsia. Best step: change NSAIDs plus PPIs. Option B, do endoscopy. Option C, H.pylori eradication. Option D, antacids only. And option E, CT abdomen. Whichever you think is correct, please note down that. And now the last question: which one of the following is recommended in all dyspepsia patients? Weight reduction if overweight, iron supplementation, option C, routine imaging, option D, colonoscopy every 5 years, and option E, surgical referral. Whichever you think is correct, please note down that. So, these are the correct answers for these MCQs. Please match with this key. MCQ 1, correct answer D. MCQ 2, correct answer C. MCQ 3, correct answer A. MCQ 4, correct answer C. MCQ 5, correct answer C. MCQ 6, correct answer D. MCQ 7, correct answer C. MCQ 8, correct answer D. MCQ 9, correct answer A. MCQ 10, correct answer A. So please give marks to yourself and see whether there's any difference between pre-test and post-test. You can share your results, your comments on my YouTube channel under this video in the comment section. And I would like to continue this discussion going on. So thank you very much for being with me in today's lecture. And I tried to give you a practical and clinical approach in a patient when he or she presents to you with dyspepsia. Dear colleagues, we have discussed the modern practical approach to dyspepsia and reviewed how to apply it through real-life clinical scenarios. There are a few key messages I would like you to take home. First, dyspepsia is common, but serious disease is rare. Do not over-investigate, but also do not miss the danger signs. Second, age and alarm features guide decisions. Many patients can be safely managed without endoscopy. Third, test and treat H. pylori is useful in our population, but timing and technique matter, especially regarding stopping PPIs and antibiotics beforehand. Fourth, functional dyspepsia is a diagnosis and not a failure. It needs reassurance, lifestyle advice, PPIs are prokinetics, and sometimes psychological support. And fifth, education is therapy. A few minutes spent explaining diet, stress, sleep, and expectations can transform outcomes. In every patient, ask yourself, do this patient have red flags? If not, can I manage them safely and confidently without invasive tests? This simple triage prevents both overtreatment and undertreatment. Thank you for your attention and active participation. I hope the algorithms and practical tips shared today will help in your daily clinical practice. I look forward to your questions, discussions, and feedback online if possible. Thank you very much.